Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith Rogers. Today, a look at what the budget reconciliation bill will mean for the Affordable Care Act. Liz Fowler is an expert in federal health policy and a Bloomberg Distinguished Scholar at Johns Hopkins. She has worked at the Centers for Medicare and Medicaid Services, and prior to that, she served on the Senate Finance Committee, playing a major role in the drafting and passage of the Affordable Care Act. Let's listen. Liz Fowler, thank you so much for joining us on Public Health on Call. Would you tell us a little bit about your work and your background?
Thanks, Lindsay. It's great to be here. I am currently a distinguished scholar at the Bloomberg School of Public Health at Johns Hopkins and also with the Carey Business School. Before this, I was leading the CMS Innovation Center. That's the innovation center that's part of the Center for Medicare and Medicaid Services. But I think the reason we're talking today is because during the drafting of the Affordable Care Act, I was the chief health counsel of the Senate Finance Committee, which had jurisdiction over Medicare, Medicaid, and many other policies that were part of the ACA that's become known as Obamacare, and now will be undergoing some changes as a result of the legislation that just passed.
That is exactly what we want to talk to you about today. There's a lot that we're still unpacking about budget reconciliation, particularly on healthcare and the ACA. But to start us off, what is the Affordable Care Act? What did it do?
The ACA was really an attempt at covering the uninsured. So our uninsured rate, the people without health insurance coverage in the U.S., was about 18% in 2009, 2010 when the ACA was drafted and when it passed. And the ACA, instead of creating a whole new healthcare system, sought to build on the existing healthcare system. As messy and complicated as it is, tried to build on the pieces that were there in place already to fill those gaps. So for very low income, tried to expand Medicaid to cover those below 138% of poverty. And then for this middle income category, maybe you retired early, you have multiple jobs, but your employer doesn't offer health coverage, or for whatever reason, you're buying your own health insurance, created these ACA marketplace plans in every state to buy your own coverage with certain subsidies if you were at the lower end of the scale and less of a subsidy as you move up the scale. And so really tried to fill those gaps, and we did. The uninsured rate was about 8.2% in 2024. And it's not 100%. It's not a perfect approach, but it was really trying to fill some of the holes in our system back in the time.
And now, how are these things going to change moving forward?
As I'm calling it, OB3, I don't want to call it a beautiful bill because I don't think that it is. OB3 is really making some pretty big changes to the ACA, both the Medicaid expansion part of that law and the marketplace plans that cover other populations. And I think some people have said it's like a repeal of the ACA, but without the replace. I don't know that it goes all the way to repeal, but it certainly makes really big changes in a way that's going to scale back and I think undo some of the progress we've made in covering the uninsured over the last 15 years.
And what are some of the ways that it's going to reduce access to coverage?
Well, I think you have already talked about on your show some of the important changes to Medicaid, like the new work requirements. So if you're considered a quote-unquote able-bodied adult, you're going to have to be working in order to receive Medicaid benefits or doing community service. There are certain standards that still have to be fleshed out. There is a more frequent what's called a redetermination. So you're going to have to keep reapplying for Medicaid. You're not going to be able to keep your coverage for a full year. And there's changes in the way that funding will flow to states for their Medicaid programs. That's on the Medicaid side. And then on the marketplace side, there's also some important changes that I think are getting less attention because most of the attention is going to the Medicaid pieces. But enrollees in marketplace plans are going to have to re-enroll every year. So there's no automatic re-enrollment. You're going to have to go into the website and you're going to have to fill out your application each year. This year, let me just say, 10 million people were automatically re-enrolled. That's not going to be the case. And so I think there's a lot of concern that people may not know they need to do that and lose their coverage. And also the open enrollment period was shortened by a month. So now you have less time to go in and actually make that application. If you're a new enrollee who needs to prove your eligibility for certain subsidies, you're going to have to prove that you're eligible before those subsidies take effect, as opposed to we'll give you the benefit of the doubt and then go back and do a look back. And then you're going to have to update your information every year. I guess that goes along with reapplying every year.
When do these changes take place?
Well, most of the ACA marketplace changes take place starting this fall for plan year 2026. So those are pretty big changes that people are going to need to understand really quickly and prepare in order to get ready for the next enrollment period. And Lindsay, I think it's also worth mentioning what wasn't in the OB3 Act, which is an extension of the enhanced premium subsidies. So the enhanced premium subsidies were not part of this bill, which means that premiums will potentially increase substantially in a lot of states. I've seen a lot of estimates, anywhere from 25% to 75% premium increases, depending on your income level and where you live and what sort of coverage you're purchasing. So a lot of really big changes happening that folks, I think, really haven't focused on.
Let's talk about some of the other changes. You've mentioned eligibility in terms of income status. What about things like citizenship?
Yeah, I think some states have been trying to cover immigrants, and some of those were not documented. They were undocumented immigrants, and they were funded through state funding. The law prohibits states from providing that coverage. I think there were folks that are covered under DACA, the Deferred Action, folks who were brought here as children by their parents, and they were allowed to enroll in Medicaid, and that eligibility category will be ending. And then just, I think, increased attention to immigration status. So generally, folks are going to have to make sure they have everything lined up and all their information to make sure that they can apply for coverage and make sure there's no gaps in coverage.
Can you tell us a little more about why these changes are being made? What's the intent here? What are they trying to accomplish?
I think the fundamental question comes down to whether you think healthcare is a right or a privilege. And I think under the ACA, it felt like we were moving more and more into the space where people felt like healthcare was a right. You should be able to access healthcare. You should be able to get preventive benefits, to see a doctor. You shouldn't have to rely on the emergency room to access healthcare. But I don't know that everyone believes that. And I think this OB3 is an indication that some people feel like you still need to be deserving of healthcare. You need to be working in order to be eligible for subsidies, for Medicaid coverage, for example. And I find that odd and anachronistic, because if you look at even employer-sponsored coverage, that's been declining over time. And so it's still the predominant way many people receive coverage. But I think you can't rely on an employer to provide coverage. I think the modern workforce, people have multiple jobs, and they may not stay in the same job as long as they used to when, for example, my father had the same job for his entire career. People don't do that anymore. And so I think not only, in my personal opinion, should healthcare be a right and people should have access, but I also think that the law and the ACA tried to recognize that we're in a new era, and it is really difficult to tie healthcare to employment status. And let me just say, the other irony is that one of the largest, or if not the largest, public expenditure in our U.S. tax code is for employer-sponsored health coverage. If you're employed and you're getting a subsidy from your employer, you're not paying tax on that as income. And that is a huge expense, but it's not applied equally across the system. And so we have a patchwork quilt of coverage. And I think if you think healthcare is not a right and you think that you ought to earn your coverage, you were probably happy with some of those changes. If you're someone who's trying to get by and you're working multiple jobs and you just want to make sure your family can get health coverage, I think this is going to be a real setback.
And when you say setback, you mentioned before that it was like 18% of people did not have healthcare coverage. This setback isn't like we're just going to go back to 18% of people again don't have healthcare coverage. What do you see happening?
Well, I think the estimates by the Congressional Budget Office is that about 16 million people are going to lose their health coverage as a result of this legislation. And I think people don't realize it. Even if you're on Medicaid, you might not realize you're on Medicaid because every state calls their program something different. And so you might think, well, okay, I'm fine because I don't have Medicaid, but it turns out you might actually have Medicaid. So these changes, I think, are something that everyone needs to focus on. And by turning back the clock, we won't go all the way back to 2010 to pre-ACA. There's still protections for people with pre-existing conditions if you try to buy health coverage, but in terms of rolling back coverage. And this has been a century-long battle in our country to think about how to provide health coverage. We've been trying for the better part of 100 years to move towards some sort of system where everyone is covered. And we have had fits and starts. The ACA was a big step forward. It wasn't 100%, but it made a lot of progress. And now we're winding back the clock.
Last thoughts?
I think I try to be optimistic and think that Medicaid in particular is an incredibly resilient program that allows a lot of state innovation. States have crafted their programs for their individual state needs. Some have done better than others. And I think that the program will survive, and I think it's much stronger than it was going into the ACA. There's a lot more people relying on it. And I think once people realize some of these significant changes and how they're impacted, I think you'll start to hear more outcry and calls to rethink some of these policies.
Liz Fowler, thank you so much for joining us on Public Health on Call.
Thanks, Lindsay.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharpstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.